And so the next talk is, when I say views from the healthcare systems, it's a very different view than I've been sharing so far. Again, my disclosure, nothing particularly relevant for this talk. So the guiding principle in radiology is that imaging doses should be as low as reasonably achievable to minimize the potential for harm. I told you earlier that I was not so excited about that as our only principle because it doesn't seem to be leading to consistent dosing. In clinical practice, CT radiation doses vary substantially across patients, hospitals, and countries, even accounting for factors that should help us have more standard doses. So why is that? In the earlier presentation, I shared the results of our randomized trial that showed audit and feedback and the sharing of best practices can lead to lower doses. That sharing of best practices meant we taught organizations how to do quality improvement, and we allowed them to share every week what their quality improvement project was, what their results were, their challenges. It was a really very interactive process. But the work of participating in our collaboration and being able to make changes in response to that participation was a lot of work. Leaders in these healthcare systems engaged in specific strategies to optimize doses within their organizations once they learned of the results in our trial. So we might have said your chest doses are particularly high. They had to then figure out how we're going to change those doses. And the strategies that these health systems use at the organizational level is the focus of this presentation. The prior presentation focused on analyzing the results of a detailed survey, asking each facility a standard set of questions about how they manage quality improvement at their organization and how they specifically manage radiation dose. But this presentation focuses on conversations that we had with organizations, a qualitative study to understand their unique experiences and their situation. And what I'm going to share comes from two manuscripts that have been published, both led by Robin Whitebird, a qualitative researcher. The first one, Barriers to CT Dose Optimization, the Challenge of Organizational Change, and the other flip side of the coin, Strategies that were used for dose optimization successfully, both views from the healthcare system. Again, to do this work involves understanding complex organizational structures, and to understand who was successful and who was not, we wanted to learn what their organizational structures were. So this, again, is a qualitative survey rather than a quantitative survey, and we used interview data to explore how organizations perceived barriers and change for CT dose optimization in their organization. And this is basically narrative interview data, and it provides a rich opportunity to understand the dynamics of individual systems with a very small set of unique participants. This is the other extreme of when I'm showing you results on 800,000 patients. This is rather results of discussions with 21 leaders. The goal was to identify the organizational leaders responsible for CT's dose optimization at each organization, to make sure that we spoke to the right people. Again, diverse settings, and the results I'm going to share reflect the results of 21 semi-structured telephone interviews that were conducted between 2017 and 2018. We created a detailed interview guide. Again, these were open discussions, but nonetheless, we tried to have them follow a pretty standard pattern. There were 13 questions. We asked about different groups of individuals, leaderships, techs, RADs, et cetera, for what was the importance of dose optimization, perceived importance to that group, the approaches they used to optimize dose, the strategies to implement change, and what barriers were encountered. We used structured probes to explore topics more deeply. There was a single trained interviewer, Robin Whitebird, who conducted these interviews over the course of 6 months, and each interview averaged about 30 minutes. It ranged from 19 to 40 minutes. These discussions were audio recorded and professionally transcribed. So at my organization on the bottom, this is the study design. In a minute, we'll get to the barriers and facilitators that were identified. We use something called a directed content analysis approach to explore organizational strategies and barriers to change around CT dose optimization. The data were modeled within the theoretical framework of something called the practice improvement model. I mentioned it earlier, that was developed for improving primary care, and that provides a theoretical structure to assess organizational change. We use in vivo software for the qualitative data to structure and code the data. And then once the data were coded, 3 authors experienced in qualitative analysis independently reviewed all the data and then met to systematically code and identifying patterns, categories, and themes. The practice improvement model, again, provides this framework for how we can understand how well an organization can make change. There's organizational priority for change. There's something called the change process capability, and there are specific strategies that can be facilitators to this or specific strategies that can be barriers. It's basically defined as an organization's capacity to use systems or work level strategies to alter care processes. And the care process structure is basically how our patients cared for. And there are specific strategies that can enhance, facilitate dose optimization or can be barriers. And sort of a combination of these factors will lead to whether or not they have CT dose optimization. I wish we had such a model in radiology. We have no such framework, and so we borrowed from this framework that's available within primary care. So there were 19 organizations, the same as in the facilitators and barriers, the same interviews that are used. 19 organizations, 26 participants, including 11 radiologists, 8 medical physicists, 2 CTECs, and 2 operational managers, directors who had direct responsibility for oversight of radiology. The respondents were predominantly male and white and had been at their healthcare organization an average of just under 10 years, a range from 11 months to 25 years. So this analysis identified 6 primary barriers. We're going to begin the discussion with the barriers, followed by the facilitators of CT dose. There were 6 primary barriers to dose optimization: resistance to change, limited time and resource, complex organizational structure, lack of leadership support, variation in CT equipment, and variability of protocols. I should point out that I mentioned in the last presentation that the question about resources, do you have enough resources, was not associated with having lower doses. In this qualitative survey, however, we heard some differing results. So it's getting at the truth in different ways. So these are the 6 barriers. Resistance to change. In some, it meant radiologists preferred better quality images and they were concerned about diagnostic accuracy. Limited time and resources was essentially that other pressing issues competed for time and resources. The organizational structure basically was the size and how decision-making happened. Was it centralized or localized? And how it was decisions were made with the other departments that were in coordination. So the emergency department or oncology. Lack of leadership support, basically that other competing priorities compete for leadership time and attention. And then variation in CT equipment, that it was challenging in different machines, and that variation in protocols. And because this was a qualitative survey, I want to dive into each of these issues a little more to give you a sense of what we heard from the people that we spoke to. So first, resistance to change, especially by radiologists, were cited by 88% of respondents as a primary barrier to dose optimization efforts. There are 2 things that have this high of a reporting rate, and this is one of them. Respondents described pushback from radiologists and noted that radiologists were pretty resistant to dose optimization efforts. Radiologist resistance focused on image quality and were due to 2 concerns. And on these slides, I've shown direct quotes in green text. The first was that lowering doses would reduce image quality. Images will be too noisy, and that this would inhibit their ability to make accurate diagnosis. As one respondent noted, there was only one barrier, that you had to convince your team that you can lower the doses, but that you can keep the diagnostic information. The second concern related to personal preferences for high-dose exams. I think this is super important. Respondents noted that the radiologists have strong personal preferences regarding image quality that was developed over years of training, and as a result, they could be resistant to change, even if they didn't think it would impact their diagnostic ability. In discussing this, a respondent stated, I think we can lower our doses and still get optimal images, but we've had physicians who said, I don't want any radiation dose reduction. I want my scans to look beautiful. Radiologists may resist change to imaging procedures that they are accustomed to, even when they believe reducing doses won't impede diagnostic accuracy. And I think learning from this research that facilities and radiologists might feel that way suggested to me that we can't just say everyone should choose their own image noise, image quality, and their own dose and expect that we're going to get anything different than we get, which is incredible variation. And so I think having some external guides, some benchmarks that are outside the organization are really key if radiologists, even when they think the images are going to be diagnostic at lower doses, still don't want them. The second challenge, the challenge of limited time and resources to focus on dose optimization, was discussed by 61% of respondents, a great number. And this included the inability to hire appropriate staff, including medical physicists. One respondent noted, I think the one that was the biggest barrier and probably will remain the biggest barrier is just not having on-site physicists and not having the degree of expertise. Dose optimization efforts can take and will take considerable time, and a respondent noted other priorities. I would say we're understaffed, chronically understaffed. There are always things that seem like they're more important than making those changes to the protocols. And not to say that radiation dose optimization isn't important. It's just that there are so many other pressing needs for day-to-day radiology that just get in the way. So it's just not on the top of the priorities. Directing resources for dose optimization efforts was also a challenge. One respondent noted, it just comes down to having a lack of resources. And another said, I think the barrier was you have to take the time to look at these things and analyze, and then get back to them and follow through. And that follow through requires having manpower and resources. One respondent summed up research challenges as, I think the organization would like to support it, but at the same time, they are limited as to what they can dedicate for that. So it's definitely a barrier. The next was organizational structure, including size, how decisions are made, centralized or localized, relationship between subgroups, and overall cohesiveness. This, as a group of issues, was noted by 50% of respondents as substantially impacting their ability to institute change. I should point out, on these surveys, often barriers and facilitators are identified by relatively small number of participants, where there are a lot of potential reasons that it's difficult to implement change, and you have to do so many things. For ours surveys, there weren't really that many that were important, and the ones that we identified were reported by a huge proportion of our participants. So organizational leaders' desire for standardization as a way to drive changes can be at odds with the local unit's interest in making their own decisions. A respondent noted, I think the biggest barriers that we tried to deal with right from the get-go was standardization, because each site is basically its own entity, and it's a very complex situation because the difference in culture. One respondent noted some smaller facilities, they're a little too relaxed, and to get them to do an extra step is kind of difficult. And remote hospitals and the radiologist groups at those hospitals, I think getting them to participate was the hardest thing. I want to interject a point here that I think was something that I learned from our survey. I showed you in one of the figures the range in dose for abdominal CT across all of the organizations. I showed you that there were more European hospitals in the low dose, more Japanese hospitals in the high dose. But I also showed you that the US hospitals were in the absolute best category and the absolute worst category. And I don't think it was necessarily be obvious to someone to guess which one was which. And what I mean by that is one of our absolutely best hospitals was a small community hospital in Texas, where a lead technologist was just passionate about making this his priority and optimized dose to an amazing degree. And one of the best European ones did similar work in Europe. And then at the high extreme of doses, our highest doses was one of my most premier academic institutions. So you wouldn't necessarily guess correctly if you said only the largest resourced hospitals with the most academics and most medical physicists on staff have the lowest doses. It wasn't that we didn't find that to be the case in our experience. So next, lack of leadership support was identified by 50% of respondents. They spoke of competing priorities that garner more focus and more support. One respondent noted, we have a lot of different competing priorities, and if this was made a priority from our C-suite, change would happen. This was such an important lesson for me. Maybe it's obvious, but you have to get your quality issue on people's agenda. And even now, when we've known about dose optimization, really has been in the news and in our publications for many years, it hasn't become a priority issue. There are so many other issues. We have major staffing issues in radiologists, medical physicists, and technologists, and radiation dose has not been on top of the list. And you need some way to get this to be of interest in the C-suite to get change. Another respondent said about leadership, they're neither supportive nor not supportive. They're happy that we want to do something like that, I think, in general. They're on board with things that will foster patient safety. But on the other hand, things like data security and patient information protection are very, very high on the hospital's list of importance. In larger structurally complex organizations, administration awareness of dose optimization efforts were unclear. When I first started this work, the radiation overdoses became an interest for medical malpractice regions. These were gross errors, and hospitals at that time were really concerned not to have these liability issues, where that issue has gone away, and I think there's been waning of interest. Respondents were asked during these interviews about their perception for support of optimizing CT from various groups within their organizations. The perceived importance for various groups about the need to optimize CT dose varied, and the administrative groups outside, external to radiology, scored the lowest. They had least concern about this issue, meaning that the broad organizational support for CT at these large organizations could be very low if the administrators didn't even know it existed as an issue. Respondents noted that while organizations may provide initial support, ongoing material support or recognition for the efforts was often lacking. We're jumping now to the other category, barriers in care processes, where there were several issues that came up as high. Over half of respondents, 57%, discussed variation in CT equipment as a substantial barrier to dose optimization. Issues include differences in manufacturers and how the machines work, variation in different models, even for the same manufacturers, and differing ages of CT scanners making optimization of dose difficult. One respondent reflected, at our site, we have different scanners. They came online at different times. They all have different technology. And it was hard to talk about making changes when everyone had different equipment. Another respondent noted, I think we have 12 CT scanners and there are 11 different models of scanners. So there's a lot of variability. And because the models are different, they have different performance characteristics. So that was probably the biggest challenge in saying, can we lower the dose? Equipment age was also noted as a challenge with older technology, which provides less opportunity. One respondent noted, if you have really old machines versus newer ones, you can face differences in regards to the possibilities to reduce dose. And until we get newer scanners, some of this stuff, it kind of restricts us. The cost of investing in newer equipment was itself a substantial barrier given the high capital investment. And I should make a caveat here to something I said earlier. In our studies, we have not found that the equipment matters that much. But all of the participants in our registries have relatively new equipment. We do not have users who have super old equipment. So just a generalization that I think it's important to remember. And lastly, the variations in protocols. Intertwined with variation in equipment was variation in protocols. This challenge was due to the large number of protocols and the inability to apply a single protocol across different machines. Different manufacturers and models within manufacturers may employ different technology, and standardizing protocols across an organization can be hampered by the complexity of available machines. One respondent noted, the biggest barrier that we've seen is variability in protocols, not the least of which is because we have so many different types of scanners. Respondents noted that changing protocols across equipment and sites requires a significant knowledge, effort, and time. The major change would be better protocoling because we're still struggling with that. Getting the protocols correct to begin with, and I guess the only kind of barriers would be more actually deciding on more protocol changes. More protocols meant more challenges in identifying and changing those that need improvement. This can be particularly true in organizations where radiologists develop their own unique protocols. I hope we're going away with that, but it still occurs. One respondent noted, if you have multiple radiologists who can actually have their own protocols, there's no way you're getting the same standardization. And at some institutions, they've decided protocols by certain physicians that have names. Identifying protocols created for an individual physician can be challenging, which is one respondent called when protocols go rogue. Another respondent noted a big barrier was figuring out why people had access to protocols and why they were changing them when they really shouldn't be tinkering with them. Dose optimization is challenging when organizations have little control over the number of protocols and they increase over time. So that is sort of, I think, the challenging side of the equation. What were the barriers? But many of our organizations did a great job with their doses at baseline. And so I also want to share the results of the separate paper that shows sort of the how they got from here to there using the positive, what worked for them. And so there are 7 strategies that were on the facilitator side. And these are engaging radiologists and technologists, establishing a CT dose committee, managing organizational change, provider leadership and support, monitoring and benchmarking, modifying CT protocols, and changes in equipment and work rules. And we heard from the presentations this morning, reflecting on these same steps of what happened and made their optimization successful. We also heard some of the challenges in doing it. So first, change process capability strategies, engaging radiologists and technologists was cited by 81% of respondents. Super important. The work of radiologists is impacted profoundly by dose optimization, and engaging radiologists was viewed as a critical element for successful change. Take the time to work with the radiologist and make it a priority. Respondents discussed either engaging all radiologists or identifying a primary radiologist. Involving all radiologists, including having the radiology group sign off on proposed changes. Involving a primary radiologist was a more frequent strategy. Involved identifying a radiologist who was excited and willing to lead and champion the effort. Number one thing to do would get a radiologist involved who wants to take an active role. Without them, you can't make a lot of changes. Technologists were also critical to spreading optimization efforts with departments. It couldn't be spread just by the radiologists. By bringing in the lead techs, they'd be able to then disseminate it to their staff under them. Respondents also noted the importance of communication between technologists and the radiologists for successful change efforts. There was a lot of communication between techs and radiologists, was noted by multiple speakers. Establishing a CT dose committee was discussed by 73% of respondents, was a really important strategy, with many noted that the changes they made were driven by this committee. Respondents discussed the importance of a structured group effort for change by forming a committee where it's not left to one person or unclear who's going to do what, and noting that it takes a committee or group of people or team to make it really happen and keep it going. The comparison varied from small multidisciplinary groups to large endeavors organized as inclusive as possible, with some committees having as many 30 representatives from multiple departments or divisions, not just radiology, but across areas, who have expertise and can speak the language of each section. Committees met regularly, setting goals, reviewing protocols, and assessing progress. Managing organizational change was discussed by 65% of respondents and involved clear communication, education, and engaging with culture change. Respondents said enhancing communication established a communication route between individuals and departments, laying an important foundation. It's really important that we have a constant interaction between the different professional groups. Clear, effective communication builds relationship, enhances staff involvement in change, highlighting the importance of getting everybody on board and getting everyone to cooperate and being on the same page. Staff education efforts were also important, especially for technologists. We have formal training and some continuing education, and when changing a protocol, they needed a lot of education to be able to do that. Perhaps the most complex component of managing organizational change was addressing the culture change that comes with it. Respondents noted that optimizing dose is quite a bit of a cultural change process, and you have to create a culture to work to optimize dose. If you don't have a culture, you will always have barriers, and changing that culture, I think, really is something that needs to happen. Having leadership support was noted by 50% of respondents. If the organizational leadership is not convinced about this topic, that you should work on dose optimization, I think it's very hard to successfully implement change. Lukewarm leadership buy-in are not likely to work. And leadership support does not only include clearly stating an expression of support, but also providing resources where necessary and the man-hours to do the work. In terms of the care process strategies, monitoring and benchmarking was noted by 36% of respondents. Providing data and having data integrity so that they believe the data. I mean, you know that saying, "In God we trust," all others bring data. Monitoring data internally and then comparing that data to other organizations as a benchmark can provide new perspectives on dose organization and optimization. I think this was our most successful strategy, is we provided a mirror to organizations where they could see how they were doing and they could see how they compared with others. That was enough for many to really help motivate change. The overall sense before we started was that we were doing just fine. It wasn't a big priority, and it wasn't until we started comparing to other benchmarks and realized that they weren't doing nearly as well as they thought they would. And then modifying protocols was noted. The other question that we had 88% of respondents noting was key to optimizing doses. Respondents discussed harmonizing and synchronizing protocols, leading to increased standardization and less variation. This was particularly true of organizations with large variation in the number of protocols, as well as multi-site organizations where the protocols vary greatly. One of our collaborative sites in our intervention was a hospital system that had 8 hospitals. And I was asked at the beginning if I would please consider them all together as a single organization. And I said I couldn't. The design of our study was to work with one hospital. But it turned out that those hospitals all had profoundly different doses, and looking at them individually allowed to see opportunities for dose optimization. Reviewing protocols on an ongoing basis was seen as a foundational effort in dose optimization. One organization involved, who we heard about this morning, an innovative approach deemed Protocol of the Week. Every week we have one focused protocol that is sent out for all the sites to check their scanners to see if they're good and to make changes if need be. And we saw how successfully Emory used this approach. And lastly, equipment and work changes. 31% of respondents noted that this was important. New scanning equipment is expensive, and hence it's a less used strategy, but can enhance dose optimization through standardizing technology. New scanners provide increased opportunities for optimization, and the biggest thing without sacrificing image quality was reported is that getting new scanners. Changes in work rules was a strategy focusing on developing procedures via manual, registries, or certifications for employees. We heard about both of these this morning. We've also created a CT manual that requires everyone to come to work for a hospital to go to be educated and to be registered as a technologist. Optimizing CT dose within healthcare organization requires a complex effort, requiring a variety of strategies to reach the goals. There's not one quick fix that you can do. And I found it interesting that the same strategies can serve as both facilitators and barriers. If you don't engage with the radiologists and technologists and they don't have buy-in, then you're not going to be able to optimize your protocols. The strategies employed depend on many organizational factors and barriers that exist to optimization efforts. And while there are clear barriers, there are also many strategies that organizations have used successfully that have led to dose optimization. The primary lesson from these analyses for me is that it's necessary to engage a larger team to focus on dose optimization and to bring in leadership at several levels to make this a priority. That's the end of my presentation. I really appreciate your listening, and please put questions in the Q&A section, which I'd be happy to answer. The first question that I see is, what is your recommendation on how to get hospitals to go above the minimum quality monitoring requirements? I think that I think showing the performance of your organization compared to other organizations, ideally ones that you compete with, the hospital across the street or another sister organization, and look at your doses compared to those. I think that's the most powerful evidence. I mean, the minimum quality requirements is required. But you can get higher than that if there's motivation for doing that. And I have found, I've been a champion in this area for many years. My jumping up and down and saying, this is really important, you need to do this, it's not really that powerful. It's not that motivating. Where showing concrete data has been much better at really enhancing the leadership views for this. I'm not going to be talking about this very much in this presentation, but the CMS, the Center for Medicare and Medicaid Services, is adopting a measurement that my team developed at UCSF for measuring radiation dose and image quality. It's been incorporated into the rule for the inpatient hospital system, and it's under consideration for other programs as well. I think that will put meaningful financial penalties and bonuses at play for driving quality improvement. And I'm hoping that that will add another level of motivation. It too is not going to work by itself, but will also help motivate hospitals and hopefully physicians to improve. The next question is, was IT a barrier? I think that's a complicated question. That did not come up as standing out as an issue, but I should give a caveat that all of our collaborators in the 100 facilities that were served as our sites in our trial and our surveys all use Radiometrics. That was how we got data. Radiometrics has been a really great partner. You should go visit them during our break and see what they're sharing. They provided tools that hospitals could use. So all of our collaborators had access to dose management tools. But I've certainly heard anecdotally that people don't have access to even know what the radiation dose information is, let alone what it should be. So I think in our experience, IT was not so much a barrier, but I think it probably is a barrier for others. The next question is an interesting one. What are the effective and supportive methods to retrieve the actual scan protocols from various CTs across various hospitals? Visiting each site sounds exhausting to me. So I can't tell if the questioner is asking for their own organization how to get the protocols, or just to learn about protocols from all other sites. I'll answer the second question, which is there is not really an effective way to currently get protocols. There are some organizations that make protocols available, some for cost, some free if you're using their machines. But I think it's an area that radiology really needs to step up to say these are good protocols. And my team is doing a lot of work. I have a few slides in one of the later talks that I'm showing you how we're trying to develop that. But I think we need to have a better way as a profession of sharing protocols, if not considering them proprietary, but rather these are the good way to scan patients. They work. I'll show you later sort of some of our ideas on it and to share those. But in terms of getting protocols from within your organization, those are also not readily available. Many hospitals put them online, but for many, you have to go to each individual hospital and look at the protocols, and that's how you have to update them, which I think is a real limitation. It shouldn't really be that complicated. The last question that's up is the takeaway is that there are so many local barriers that require organization-specific fixes. This would mean change happens site by site. That feels slow and incremental. What sort of efforts are underway to encourage quality improvement at a larger scale? For example, are there any efforts by payers or professional societies or the Joint Commission to implement requirements to have some solutions in place? Like having a CT dose committee or benchmarking doses. I think this quality measure that I mentioned that CMS has adopted is a really good first step in that. It sets up for different kinds of CT. So it looks at why CTs were done. For example, in the head, was the scan done for sinusitis, for trauma, for acute stroke, for a headache? It puts CT scans based on why it was done, based on billing, diagnostic codes, and procedure codes, and then looks at the dose for that scan against benchmarks that it created specifically for low routine or high dose brain scans. And it judges each scan based on the dose and based on image quality, that it's not extremely unacceptable. And I'm looking forward to the implementation of this measure because I think it will help start to create benchmarking that people are comparing their doses to. I think having that is really the first step. In terms of what you can then do with that information, I think well-known strategies, you need a dose committee, you need to have regular review of your protocols to ensure that you're meeting those, I think will come after the standard way of comparing your doses. If we're all comparing to the same standards, then there's a motivation. And I think part of the reason CMS was interested in implementing the measure was their acknowledgement that there's variation that's just unnecessary and that's leading to harm. And there's one more question. When we modify the CT protocols, how do we determine the appropriate image quality? Or how do we determine the minimum possible dose CT-DI vol? Again, the ACR has published average doses, and so there's no reason your average doses should be different than the ACR guidelines. For our quality measure, we've published explicit criteria for different studies, both with respect to image noise and dose. And the measure is still under consideration for 2 programs. So it's a little tricky for you to find those benchmarks, but my team will be publishing them so you can then compare your studies based on why the study was done to these very explicit benchmarks.